Hello, everybody. I'm Dr. Chandana. I'm consultant Pediatric Haematology and Oncology at KIMS Hospital, KIMS Cuddles. So today we're going to just talk some basics and some insights into what is febrile neutropenia and how do we manage febrile neutropenia. This is most commonly seen in children, especially in kids with cancers. And also immunodeficiencies. So it becomes crucial for us to manage febrile neutropenia because it is supposedly very life-threatening if not treated in the first 1 hour. So when do we say it is febrile neutropenia? When do we say it is febrile neutropenia? So does 38 degrees centigrade define febrile neutropenia? What is absolute neutrophil count? Has the patient received transfusions in the last 6 hours? Is primary disease known to cause fevers? And why first hour is crucial in febrile neutropenia? These are the questions which we need to answer. So coming to the definition, a single oral temperature of more than 38.3 degrees centigrade, that is 101 Fahrenheit, or a temperature of 100.4 Fahrenheit on two separate occasions, which are separated by at least 1 hour. Other signs or symptoms which are consistent of with clinically significant febrile neutropenia. Sometimes there might not be fever. Sometimes they can present with lethargy, abdominal pain, dullness over the last few hours. So all of this we should think that it might be sepsis. And for example, if there is a temperature of 37.7, so what do you need to do at that time? So at that time, we need to repeat the temperature in 1 hour, check the vitals, and generally these cancer kids have indwelling catheters which are already in place, and we need to be sure that these are not the source of infection. Next. Any patient with or without fever who has features suggestive of systemic infection, they should be treated with intravenous antibiotics. And unexplained generalized or abdominal pain, unexplained vomitings, hypothermia, maybe these are subtle signs of sepsis. And we should also look for other signs of sepsis like abnormal vitals, lactate, gas, or end organ compromise. So we need to have this in the background when a patient with neutropenia is febrile. So there is a decrease in the concentration of neutrophils in the blood. And what are neutrophils? These are one kind of white blood cell counts that help to fight infection. So the febrile neutropenia, we have different risk stratifications. So one risk stratification is MASCC risk index. So in this, we have there are a few parameters which we see, and there are a few scoring which we do. And based on these scoring, MASSC more than 21 and less than 21 is what we generally consider. So if there is a burden of febrile neutropenia with no or mild symptoms, the score is 5. If there is no hypotension, that is systolic blood pressure more than 90 mmHg, the score is 5. No chronic obstructive pulmonary disease, the score is 4. So MASCC, this is even for adults, but for children, any kind of pulmonary disease, that is 4. Solid tumor or hematological malignancy with no previous fungal infection, the score is 4. No dehydration requiring parenteral fluids, 3. Burden of febrile neutropenia with moderate symptoms, that the score is 3. Outpatient status is 3. Age more than 60 years and less than 60 years. So these are the basic things in MASSC risk index. These could be the causes, like you could see in the picture, bone marrow disorders, sepsis, tuberculosis, hepatitis, IV infusions, any immune mechanism. All of these could be the causes for febrile neutropenia. There's another score called CISNE score. In this we have performance status, severe infection, COPD, chronic cardiovascular disease, NCL mucositis grade more than or equal to 2, monocytes less than 200 MCL. So this classification becomes low risk, intermediate risk, and high risk. Score of 0 is low risk, score of 1 to 2 is intermediate risk, and score of 3 or more than 3 is high risk. So this is like a cutoff when we intervene and when we for clinicians. ANC of less than 500 or less than 1000, or you predict that there could be a decline to less than 500. That is all called neutropenia. So ANC is total WBC into percentage of neutrophils. Sometimes we don't get the differential count, so that time this becomes important. But most of our centers now have the differential count. So you have to take the total percentage of neutrophils, which includes both the polyps and also the percentage of bands. So generally we don't consider bands, but also bands also are, we need to consider them in the neutrophil count. So history taking, we need to know what is the primary disease, why there is febrile neutropenia. Is it because of cancer? Is it because of infection? Is it because of a viral illness? Or is it because of immunodeficiency? And if there is a cancer, and we need to know the remission status, is the patient under remission because of the chemotherapy, or is he still in active disease? Any history of splenectomy? If there is a history of splenectomy, you need to be sure that Streptococcus pneumoniae, all the round encapsulated organisms here, vaccinated and prior these vaccinations done. If the splenectomy is done, then you suspect the encapsulated organism infections. Focus history of other organ systems, localizing symptoms, history of likely source of infection, immunization history of comorbidities, and inquire about indwelling catheters. Chemotherapy history, drug history, steroids and any previous antibiotics or any allergies. Transfusion history, oncology patient often receive blood transfusion that can cause fevers. So this becomes important because sometimes after blood transfusion, in the first 6 to 12 hours, at least in the first 6 to 12 hours, if there is a temperature, you don't need to actively intervene and give antibiotics. So that time you need to take a history of blood transfusions, and if there is a prior blood transfusion, you can wait for 12 hours if the patient is absolutely fine and no other clinical deterioration. You can wait and then assess again and then start antibiotics. But if the patient is sick anytime with even fever, without fever, the patient looks sick, for a clinician, you need to start off antibiotics. Examination findings, you need to look for the oral cavity, look for oral ulcers, examine the pharynx, skin examination, especially during the bone marrow aspiration sites, vascular access sites, and tissue around the nails, any rashes. Look for right lower quadrant tetanus for signs of typhlitis, which is quite common in neutropenic enterocolitis. Careful respiratory and abdominal examination, since they are a common site of infection. Timing of febrile neutropenia. Most chemotherapy agents, protocols for neutropenia added at 10 to 14 days. Generally, when you give a chemotherapy, 10 to 14 days later is when you expect the counts to fall down, and then neutropenia and then fever. So can be seen anytime from few days after chemotherapy to up to 4 to 6 weeks later, depending on the agents used. Some of them are quite myelosuppressive, especially in AML regimens and regimens. It's quite myelosuppressive, and you can wait for 28 days to 33 days sometime to, for the neutrophils to improve. Severity of neutropenia. So the normal ANC count is 1500 to 8000 mm3. Mild, moderate, severe, profound. Mild is 1000 to 1500. Moderate is 500 to 999. Severe is less than 500 and profound is less than 100. So how do we investigate? We first have to do a CBC with peripheral smear. In the biochemistry, we have to get the electrolytes, renal, liver function, and other organ specific blood test. The full blood count in peripheral smear, we can find, if there's a viral illness, we could find some toxic granules or some things like that in the peripheral smear. So we should get a peripheral smear in that sense. Then microbiology, blood cultures, peripheral and central line humans, CSF for culture, oral ulcers or sores, exit site swabs, wound swabs, urine culture, stool culture, all these become important in febrile neutropenia. So sometimes the fever is not subsiding, and you have a strong clinical suspicion there might be a CNS infection, like meningitis or encephalitis, we could do it, but it's generally not recommended as a routine. And you need to see if the thrombocytopenia is profound at that time to do a aspiration of biopsy of skin lesion suspected of being infected would be performed for cytological testing, gram staining, and culture. So this is how we stratify and roughly treat. So if the fever is more than 38.3 degrees centigrade oral or 38 for more than 1 hour, plus ANC count is between that point 500 to 1000, or ANC is expected to fall to less than 500, you assess and resuscitate, you stratify the patient, then you take the history physical examination like what I discussed. And in neutropenia, you should never perform a direct rectal examination, and also we should avoid giving rectal suppositories or doing any enemas if there is any constipation. All this should be taken into consideration. Early initiation of antibiotic therapy is the key. Assess patient stability, resuscitate as needed. So do the MSSC score. If there is low score that is more than 21, you can treat it in outpatient management. You should start off with broad coverage oral microbials, which generally cover both gram-positive, gram-negative, and anaerobic coverage, like fluoroquinolones plus clavulin or clindamycin if penicillin allergy. Later, you can, if based on clinical symptoms, you can start off with, if you're suspecting there is an MRSA, then you can give vancomycin or any antifungal. This is if the fever is still persistent after a few days of initiating this treatment. And then if still there is neutropenia, then at that time, based on the chemotherapy regimens, based on number of things, you can take into consideration of giving GCSF. High risk MASSC score is less than 21 in patient management. Broad coverage of IV microbials, gram positive, gram negative, and anaerobic coverage. So at that time, we can give piperacillin, tazobactam, or ceftazidime. Based on institutions. Each institution has their own kind of febrile neutropenia protocol. And so the high risk things. Like I've discussed, there are hematological malignancies, extended neoplastic disease, high-risk chemotherapy regimens, prior to health status, prior episode of febrile neutropenia, all these become high-risk status. So the stratification, high-risk or low-risk categories, factors affecting neutropenia, increased risk with severity of neutropenia less than 100, duration of neutropenia more than 7 days, bacteremia gram-negative is more profound and more seen compared to gram-positive. Underlying malignancies, any presence of comorbidities like hemodynamic instability, oral or GI mucositis, GI symptoms, neurological or mental status, intravascular catheter infection, new pulmonary infiltrates, underlying chronic lung disease, and evidence of hepatic insufficiency or renal insufficiency. This is one more classification, like risk stratification scores, Talcott classification. So group 1 are inpatients at the time of fever onset. All the inpatients are grouped under group 1. Group 2 are outpatients with acute comorbidity by itself requiring hospitalizations. Group 3 are outpatients without comorbidity but with uncontrolled cancer. Group 4 is outpatients with controlled cancer and without comorbidity. Talcott classification is generally what we follow in adults, but also we could think of using it in pediatrics. It's as part of the stratification scores, just for information. This is the MASSC score which I discussed. So, this is just like a rough algorithm of how to manage febrile neutropenia. Because these cancer patients, they must have undergone transplant also previously. So, if the patient has undergone transplant in the past 12 months, if yes, then you need to follow inpatient pathway. You can't think of doing an outpatient kind of treatment. An inpatient pathway, you have to admit and follow the neutropenic sepsis protocol, which I have told before and I'm going to discuss a bit later also. If the patient has not received HSCT, then if the patient is already an existing inpatient, then you follow the inpatient pathway. And if they're presented from home, you need to see if there is an indwelling line or there is no line. So if there is a line sepsis, that is fever and rigors. How do you confirm that? Fever and rigors on flushing the central venous line. Clinically well and not septic on assessment. So in all of these conditions, you clearly you have to admit and then treat. If there is no line sepsis, that is, there is fever but no rigors when you flush the CBC, then you can assess and follow the febrile neutropenia pathway. You can do the home care OP basis or any, based on number of things. So all these inpatient group are not eligible for home care pathway, and they need to be seen in the hospital and treated in the hospital. So this is the IP pathway, what we generally follow. So regardless of the neutrophil count or temperature, if the patient is unwell, you need to ask, senior to review and start antibiotics. Or if the fever is more than 38 degrees centigrade and neutrophils is equal to or less than 500, that is when you need to intervene. Then in your assessments, like I've discussed, history and examination, blood cultures, urgent bloods. If symptoms are less than 5 years, then you should do a urine analysis. Chest X-ray, stool culture, virology, all these regular, what we do for sepsis, that is all what we have to do. Then after that, we need to start off an empirical antibiotics and start off an intravenous antibiotics within the first hour. First hour is the key. Then you can continue this for 48 hours. And then you can start off with a monotherapy 24 to 48 hours, consider monotherapy. So generally, most of the institutions will start off on single agent, but you could start on a double agent, and then you can, because febrile neutropenia is a life-threatening condition, in the first 1 hour, we need to give the adequate coverage of antibiotic, cover both gram-negative and gram-positive. So at that time, we could start with double cover and then slowly downgrade it once the fevers are settled in within 48 hours, then assess, and then you can go on to monotherapy. Then at the blood cultures, if they turn out to be positive, then you need to give 10 to 14 days of total course of antibiotics, and then prove a blood culture which is negative. And if the blood cultures are negative, but the patient is still having fever, then you treat it, you start off the antibiotics and assess in 48 hours. You look for different signs of other, neurological, any other septic conditions, and only switch antibiotics if clinically deterioration or microbiological examination turns out to be positive. Do not routinely add vancomycin or teicoplanin. These are the things which we need to keep in mind. And if the patient is febrile, you can, if clinically well, no focus of infections and not septic or compromised at presentation, then you can consider stopping all these antibiotics. That is also one more thing. So these are the things. So if the fever is there, and if you, after 48 hours, if you adjusted the antibiotics and still there is ongoing fever, and the blood culture is positive, you review the antibiotic sensitivities. If the blood culture is negative, then you could continue the same ongoing management, and then if there is any abnormal chest findings or anything like that, then you could think of doing an MRI or anything. So oral ciprofloxacin 20 mg per kg twice daily is what we could generally prescribe. 24 to 48 hours of febrile from initiation of therapy, and then you can stop off the aminoglycoside if you start on dual therapy, or ciprofloxacin provided blood cultures are negative. PCV prophylaxis, Septran, trimethoprim, sulfamethoxam, we need to continue. We need to look at the resistance patterns, and monotherapy is not recommended for any patient. According to few guidelines. So the duration of antibiotic therapy, at any stage or after 48 hours assessment, antibiotics may be stopped. Patients are febrile for 48 hours, all blood cultures are negative, patient is clinically well, clinical judgment that patient is safe to stop antibiotics. This is when you can stop the antibiotics. Persistent temperature, you can switch the antibiotics. Even if patient continues to be febrile, consider whether aminoglycoside can be safely discontinued if patient is clinically stable and blood cultures are negative, if not stopped earlier. These are antifungals. So you need to keep in mind invasive fungal disease also in febrile neutropenia. There is a high risk of invasive fungal infection in these particular conditions: AML, relapse acute leukemia, allogenic BMTs, and high risk ALL. Low risk ALL, non-Hodgkin's lymphoma, autologous transplant, sporadic pediatric solid tumors, brain tumors, and Hodgkin's lymphomas. Investigations in invasive fungal disease, mandatory are chest, high resolution chest, CT and abdominal ultrasound. Investigations to consider are BAL, serum and BAL fungal diagnosis, MRI and CT brain, echocardiogram and fundoscopy. So what we generally follow is Ampho B, 3 mg per kg once a day, or echinocandins, micafungin or caspofungin. Continue until antifungal therapy, resolution of fever, lack of evidence of fungal infection on radiology, and improving clinical signs and raising the neutrophil count. This is roughly how we manage the febrile neutropenia. I hope I've covered most of it.